Every year we hold a special lecture, the Henry Neufeld Memorial Lecture, and this year I'm proud that we have with us Dr. Eugene Braunwald, which many of us believe is the father of modern cardiology, to give this lecture. When you go through the CV of Professor Braunwald, it's enormous. Just few selected achievements. He was one of the pioneering research and head in the National Heart-Lung Institute, the founding chair of the Department of Medicine in the University of California, chief of medicine at Brigham and Women's Hospital in Harvard. He's authored over 400 manuscripts and, as I mentioned, internationally recognized as the father of modern cardiology. Numerous awards, as one might expect, and I won't go through all of them. Distinguished Scientist Award from the American College of Cardiology, Herrick Award from the American Heart Association, Research Achievement Award from the American Heart Association, Williams Award, Association Professor in Medicine, Cobra Medal Association, and this is a very, very short list of this. He's been an author of many, many books, the textbook of cardiology, and many, many other books. He's also been many times in Israel, and this is the last trip with his granddaughter, and I'm proud and happy to call Professor Eugene Braunwald to talk to us about adventures of cardiovascular research. Professor Braunwald.
Professor Lotan, Professor Sahar, Professor Zegev, distinguished guests, colleagues. It is certainly a great pleasure and privilege for me to be asked to give this lecture. I first want to really congratulate you. Thank you. On your 60th anniversary. It is extraordinary that the state of Israel was born 65 years ago, and within 5 years you established this extraordinary society. And I think that tells us an enormous amount about the state, and it tells us a great deal about the importance of cardiology and cardiovascular surgery. It's actually phenomenal. And I am very honored to give this lecture in memory of Henry Neufeld. Henry Neufeld was a great Israeli cardiologist. He was one of the founders of this society. And he was a great physician and a wonderful scientist, and he was also a world figure in cardiology. And I remember distinctly in 1982 when I attended the World Congress of Cardiology in Moscow, and he was the president of that Congress and of that society, and it made me very proud. Professor Neufeld died too early. He died in 1986, and I point out to you, I can't go over all of the things that he accomplished in his life, but I am showing you these 2 papers which were published during the last year of his life in 1986. And he led a very important trial, the SPRINT trial, and he was also interested in the pathogenesis of atherosclerosis and the genetics of arteriosclerosis. Before this became, he was a pioneer in thinking about this field. Here are the disclosures, and I want to tell you about my adventures in cardiology, because I have considered my professional life to be a series of adventures. And the first adventure started in 1950. So this is 3 years before the organization of this society and 2 years after the birth of the State of Israel. I was a medical student. I was a medical student at New York University, and this is Bellevue Hospital, which was our major teaching hospital. And the curriculum in medicine isn't working too well. No. The curriculum in medicine in American medical schools in the middle of the 20th century was extremely rigid. There was no way for students in the first 2 years to get to patients, with one exception, and that was in cardiology. So the faculty of cardiology set up a clinic on Thursday nights for students who were in the second year before they had any clinical training. And my first experience that I had sitting in a white coat across a desk from a patient with congestive heart failure was in the Thursday night cardiac clinic. And I think that probably if that clinic had been in orthopedics, I would have become an orthopedist. If it had been dermatology, a dermatologist. And fortunately for me, it was in cardiology. And that gave me some thinking about the field. I began to think about it. And I was enormously fortunate as a fourth-year medical student to work in the laboratory of Professor Ludwig Eichner. Now, at that time, by this time it's 1952, I'm a senior student. And by that time, there were 12 cardiac catheterization laboratories in the United States, and one of them was in Bellevue Hospital, led by Dr. Eichner. And we began to study. He was studying, and I was learning, and got some publications on the hemodynamics of congestive heart failure. Now, I want to give you a picture very quickly, a picture of what cardiology was like in 1952. Cardiovascular mortality, age-adjusted, was 3 times as high as it is today. Acute rheumatic fever, very common in the United States. There were acute rheumatic fever hospitals along the East Coast. Arrhythmias, what did we have? We had quinidine, we know it's a poison. We had digitalis, and this is before there were pacemakers. Heart failure, again, digitalis. Mercurial diuretics given by deep intravenous painful injections, and a very low salt diet, 200 milligrams a day. Now, it didn't prolong life, but it certainly made people think they lived longer. Acute myocardial infarction, no coronary care units. Early mortality, 30%. Imaging, just a plain chest x-ray, nothing else. I said 12 cardiac cath labs in the United States, no left heart catheterization. Clinical trials, none. Evidence-based medicine, never. It was all my last patients, in my experience, took the place of evidence. And hypothesis-based clinical investigation didn't exist, if you read the journals at that time. Risk factor concept, no. Surgery, closed mitral valvotomy, no open heart surgery. The budget of the National Heart Institute, $200,000 a year. Now it's in excess of $2 billion a year, and people are complaining. The research budget of the American Heart Association, $40,000 a year, wouldn't even support a single fellowship today. So I was excited by cardiology. Why would anybody who was sane go into a field that I've just described? Well, there were really 2 reasons. First of all, you should have seen what the other fields were like in 1950. Just think of pulmonology or nephrology or neurology in 1950 or 1952. Cardiology was way ahead, and there were 2 possibilities. And I saw 2 openings, which I showed you on the previous slides. there were two things that struck me as a student. Number one, cardiac catheterization. It was a new technique, and there were things to be learned from cardiac catheterization. And the second was that cardiac surgery was beginning. And that was the beginning of an extraordinary change in cardiology. And I wanted to be understood it and to be part of that. Okay. So I made that decision very early, and it really began when I was a medical student, as you've heard now. So I consider my professional life to be a series of adventures. And I will go, the first adventure is in valvular heart disease. Because as I mentioned, a lot of rheumatic fever, a lot of chronic valvular heart disease, and closed mitral valve surgery was just beginning. And in 1953, I was a fellow at Mount Sinai Hospital in New York, and the pressure was on in the field. We have to be able to measure pressures in the left side of the heart, because all we could do at that time was go as far as the pulmonary artery. And there was a lot of dispute about the pulmonary capillary wedge pressure. So how do we get into the left side of the heart? And that really was my first adventure. And here's also the first paper that I published in Circulation, and it describes the hemodynamics of the left side of the heart, with study by simultaneous left atrial, ventricular, and aortic pressure, particular reference to mitral stenosis. And you see there's a group of authors, and I point out the name of Dr. Mark Ravitch, who was the cardiac surgeon. Now, these pressures, these on the left-hand side is the first time pressures were measured in the left atrium, left ventricle, and aorta of a patient, and they are balanced so that they're all on the same scale and the same zero, and you can see in black the pressure gradient across the mitral valve. This is before surgery, and this is after valvulotomy, and you can see that it has been markedly reduced. So how were these pressures measured? Well, they were measured at the operating table. Left heart catheterization wasn't possible, but these are the first measurements in humans of left heart pressures. Now, I mentioned Dr. Ravitch as the surgeon. So you can see this is a brilliant success of the operation because look at the difference between the before valvulotomy and after valvulotomy. Actually, he made us put that figure into the paper because that was the best result that he had. Of course, we presented all of the results in a table, but this is an example of a successful mitral valvulotomy. I then took a postdoctoral fellowship at Columbia University with Professor André Cournand, a French physiologist, and I was glad to be there at the time. He was the father of cardiac catheterization and also won the Nobel Prize for medicine and physiology, an extraordinary mentor. Now, the open chest measuring pressures is not a good way. You want to do it in a closed chest. And Dr. John Ross and I, working together with Dr. Andrew Morrow, this is now at the National Institutes of Health in Bethesda, the National Heart Institute, devised this technique. I have to give John Ross principal credit for that Transseptal method, and I think you're familiar with passing the catheter up to the fossa oralis and then puncturing that with this long needle and then slipping the catheter over it into the left ventricle. Well, this technique proved extremely helpful, and then it died down. But it wasn't extinguished because it came back with a roar when the electrophysiologist had to get into the left side of the heart. And this transseptal left heart catheterization has had a major rebirth, a renaissance during the last few years. Many, many more are done now than were done for hemodynamic purposes back in the 1960s, but in the 1960s we certainly learned a lot. And one of the things we learned, and I'm just going to give you two examples, was the effects of mitral valve replacement in patients with markedly elevated pulmonary vascular resistance. Now, in the 1960s, when prosthetic valves became available in the mitral position, the presence of severe pulmonary vascular disease was considered to be a contraindication to mitral valvulotomy, because it was felt that the pulmonary vascular disease was irreversible. Well, we tested this as a hypothesis, and shown on this slide is the pulmonary vascular resistance of 50 patients, 25 with mitral stenosis, shown in blue, 25 with mitral regurgitation, shown in gold, and these are preoperative measurements on the left, and all of the patients came back postoperatively. About 6 months later, it was possible to do that at the NIH, to bring every patient back. And as you can see, there was a marked reduction in pulmonary vascular resistance. So we concluded in this paper, published in the New England Journal in 1965, that this should not be a contraindication to the surgery. Now, aortic valve surgery came along later. And it came along later, and this gave us the opportunity at the National Heart Institute to do a natural history study of aortic stenosis. This is aortic stenosis untreated surgically. And as you can see, the average period of time until a patient was in approximately 60 on the average, patients did well. There was very little attrition. They did well, and then it is as if they fell off a cliff. Once they developed symptoms, their prognosis was very poor. And what we suggested at that time, in this paper in 1968, was that it was important to try to find the patients before they fell off the cliff. And of course, our approaches to severe aortic stenosis now is to try to find them before they develop left ventricular dysfunction, heart failure, angina, or syncope. My second major adventure that I want to tell you about is hypertrophic cardiomyopathy. That I had this for a limited period of time, but it was the most exciting adventure of my professional life. The first case was a patient that we had, 21-year-old boy whom I had catheterized, and found a subaortic gradient. He had severe dyspnea and angina. He had a subaortic gradient, and I felt that he had membranous subaortic stenosis, an uncommon anomaly, but it was one that was thought to be treatable by excising the membrane. Well, I went to, Dr. Morrow called me to the operating room while he was doing this. He said, there is no obstruction. He had the heart that was arrested, and he said, somebody, maybe you, me, made a huge mistake. And I asked him that if he could start the heart again, that he should measure the pressures in the ventricle, and they were elevated. And here are the findings on this patient. And you can see the pressure gradient in the left ventricular outflow tract between the cavity of the ventricle, the outflow tract, and no pressure across the aorta. We didn't quite know what it was. We called it functional aortic stenosis. We didn't know that it was, it had not been described before. And we continued to see many patients with this once you recognized it. And then lots of other people did as well, and we learned a great deal. One of the things we learned by 1964, we knew that this was a genetic disease, because here is a family tree, and in 3 generations the disease appeared, and half of the patients shown in black who had this actually died of it, or they were deceased, and it was transmitted genetically as an autosomal dominant. The other thing that we learned was that beta blockers were extremely helpful. in blocking the severity of obstruction, and they were very helpful in prolonging the ability of patients to walk. And here's the effect of propranolol on exercise in patients with hypertrophic subarachnoid stenosis. That's what we called it at the time. And you can see that with one exception, the patients were able to exercise for a longer period of time. So that was one therapy, and meanwhile, my colleague Glenn Morrow developed the surgery for it. And this is a wonderful drawing that shows us that he used a double-edged knife across his muscular outflow tract and dissected the region then with his finger and then excised. Not a great deal of tissue, usually not more than 5 or 6 grams of tissue, and the gradient was relieved. And I am cheered by the fact that now, a half a century later, both of these techniques, namely beta blocker is still the key medical treatment, although there are many other drugs. But you begin with a beta blocker, and this surgical treatment is still widely used. I left the NIH in 1968, and at the time I left, we had 126 patients we had studied, and of these, 6 had died suddenly. So the experience then, the adventure with HCM, began in 1959 when we recognized the obstruction was secondary to muscular hypertrophy. By 1960, familial association, variability of obstruction in 1962, the provocation of obstruction also. 1964, medical management with beta blockade. 1964, surgical treatment with myectomy. In 1968, the frequency of sudden cardiac death. And I left the NIH, and I left this field, and I have not made any contributions to this, but obviously I follow it. Heart failure. I mentioned heart failure at the beginning because that is what Professor Eichner was studying in his cath lab. And I became obviously extremely interested in heart failure. And at the NIH, we had the opportunity to make actually 2 observations. The first was we wanted to find a method of assessing left ventricular function. So we assessed this by radiocardiography. This is the beginning of nuclear cardiology. An injection, as you can see here, into the left ventricle. Left ventricle was entered by Transseptal catheterization in this patient who had aortic regurgitation. And then you see the stepwise washout. And that percentage reflected the fraction of the volume that was ejected per beat. So this is the first measurement of ejection fraction. This particular patient had a reduced ejection fraction, moderately reduced at 38%. And this technique is widely used, obviously. Now, one of the things that struck Sir William Osler, the great physician at the turn of the century, at the turn of the 20th century, was that patients with congestive heart failure acted as if they were in a hypersympathetic state. They had tachycardia, they had cold extremities, sweating, cold sweating extremities. They had evidence of reduced renal blood flow because they didn't put out much sodium in the urine, and sometimes they had reduced cerebral perfusion. So all of this looked like a hypersympathetic state. We were very lucky that our laboratory was next to the laboratory of Professor Julius Axelrod, who developed the techniques of measuring norepinephrine and taught us how to do it. He also won the Nobel Prize for his work on the sympathetic nervous system. And we found that patients with congestive heart failure do have that. William Osler was right 60 years earlier that they do have an increase of sympathetic activity. As you can see on your left, the excretion of norepinephrine, 24-hour excretion into the urine, was normal in patients who were class 1 to 2. New York Heart class, elevated in class 3, and further elevated in class 4. And on the right-hand side of the slide, you can see that the circulating norepinephrine was elevated, particularly during exercise above the normal range. And of course, this shows the great overactivity of the sympathetic nervous system. We were not smart enough. We were not smart enough to think about beta blockade. Beta blockers became available around this time. We have to credit the Swedes with saying, well, maybe this increased sympathetic activity isn't always good for the patient. Now, the second neurohormonal abnormality came much later, after I had moved to Boston. And it was done in collaboration with Mark Pfeffer and a group of other skilled investigators. It was by the time I had started to go into multi-center trials, and we studied the effects of a ACE inhibitor, captopril, in patients who were post-myocardial infarction. They had a reduced ejection fraction, but they did not have overt heart failure. And we saw that there was a marked reduction in mortality, a highly significant reduction in mortality when these patients were followed out for a period of 4 years. I want to turn my attention now briefly to lipid lowering, and just tell you about some fairly recent work. This comes from the TIMI 22 trial and the Prove It trial, in which was led by my colleague at TIMI, Chris Cannon. And the objective of this trial was to compare the usual dose of an average statin, pravastatin 40 milligrams, a dose that was widely used, with atorvastatin, which had a much more powerful effect on lowering LDL. The patients were patients who were a few days after acute coronary syndrome. So these are post-acute coronary syndrome patients. And what we observed was a 25% relative risk reduction with lowering the LDL. The LDL in these patients was about 100 on the average on this dose of pravastatin, and it was about 72 in patients with atorvastatin. A distinct difference. Lower is better. Now, one of the things that surprised us a great deal when we did this trial was that when we examined what happened in the first 30 days, you can see that the curves begin to separate out here at about 12 to 13 days. You can see that they begin to grow apart. And by 30 days, you already have a 33% reduction, which is statistically significant. Now, I think, or we think, that this is too early to be simply due to the lipids. And I think this is where the pleiotropic anti-inflammatory effects of the statins come in. Here is a study also led by Chris Cannon on the effects of a cholesterol. This is a new agent, cholesterol ester transport inhibitor, on patients with coronary disease who had already been treated with a statin. And on your left, you can see that this CETP inhibitor called anacetrapib, this is a drug that has been developed by Merck, produced a 40% further reduction in the LDL. So reduction from about 80 to 45. And on the right-hand side, you see that it produced a profound increase in HDL. It more than doubled the HDL. Not shown on this slide is the effect that lipoprotein a was also reduced by about 20%. And we are currently engaged in a trial called Heart Protection Study 3 to 55. It is a collaboration between Oxford's group under Collins, under Rory Collins, and TIMI, in which in this REVEAL trial, in which we are studying the effects of anacetrapib against placebo. It's a large trial, 30,000 patient trial. Most of the patients have already been randomized, and we are following them obviously very closely. Finally, I want to end with making some remarks about myocardial ischemia and infarction. When I came to the NIH, which was in 1955, I worked in the cardiovascular physiology department, actually, not on the clinical service, but first I put in my years in physiology. And I worked under a brilliant physiologist, Stanley Sarnoff. And the problem that we worked on was to determine the oxygen consumption of the heart. What controls the amount of oxygen, the amount of energy that the heart requires? And the device, the apparatus, the design was quite complex. And I only show you that this was an isolated heart. It was still in the dog, it was in situ, but the dog was no longer living, and we were able to control afterload, preload, the work of the heart, obviously the temperature, and we're able to continue this for about 15 hours because there was a second dog, was the support dog, which kept all of this alive. Now, in these studies and others, we determined that oxygen consumption is controlled by the tension development by the ventricle, the contractility, which is the rapidity of tension development, and the heart rate. And it's not controlled much by stroke volume, and therefore stroke work the way an engineer calculates work was not important. These were the three important determinants, and these were significant but less important. Well, that led to our thinking about if we know what determines oxygen, can we do something about it in ischemia? 1968, I was now at the University of California, San Diego, and working with a very talented colleague, Burton Sobel. We wanted to look at myocardial infarct size, and he had developed a technique by recording release of CKMB to estimate infarct size. So we had 58 patients, and you see their mortality was pretty high, 21%. And then we looked at how infarct size influenced that. And patients with an infarct size that was elevated, about half the patients had an infarct size that was more than 50 gram equivalents, and 28 patients less than 50. And you can see the difference in mortality. So it's the big infarcts, obviously, that caused the problem. And that led to the idea that can we modify infarct size? And we carried out some experiments. This is in San Diego at the University of California there. Peter Marocco was a very talented research fellow, and this was a canine study in which we produced myocardial coronary occlusion, myocardial infarction, and used many interventions. And this was the conclusion. This was the last sentence of this paper. In patients with myocardial ischemic injury resulting from coronary occlusion, measures designed for reduction of oxygen demand and improvement of coronary perfusion, when effected promptly after a patient has been brought to a hospital, might reduce the ultimate size of the infarct. So we didn't know how to do this, but we felt that by reperfusing the myocardium, it might be possible to salvage infarction. Well, the first person to do that was Eugene Chazov in Moscow. And this shows the first successful lytic occlusion, lytic revascularization. On your left, you see a right coronary artery, which is interrupted here, and then on your left and on your right, you can see that after the infusion of streptokinase, this is a pretty ratty-looking left coronary artery, but still it shows effusion all the way through to the inferior wall of the heart. So coronary reperfusion was on the map, begun by Chazov in 1976. In 1981, we were doing these in Boston, but what we wanted to determine was, did this actually salvage myocardium? Was it any good? And the answer is yes. We used streptokinase at the time, and we used intracoronary thallium to prove that that tissue had become viable after reperfusion. Well, TIMI started in 1985. TIMI stands for thrombolysis of myocardial infarction. The NIH asked me to lead it, and the first trial we did was we compared TPA and streptokinase and found that TPA resulted in 70% of the patients showing coronary patency, streptokinase in 43%, obviously better. When we followed the patients for a year, we found that those who had patent coronary arteries had a 40% lower mortality than those who had occluded coronary arteries at 90 minutes. And this led to the idea, pretty obvious, that we should attempt, however possible, to open occluded arteries early. Now, I'm not going to go through all of the TIMI trials because we don't have the time. I'll just end with the last one, Laplace TIMI 57, which has recently been completed, and it was with a PCSK9 inhibitor, which is a new LDL lowering drug. It's a monoclonal antibody, and it's really remarkable. You can see that it's a monoclonal antibody, so therefore it requires injections. So here are the effects on LDL cholesterol. You can see that they are reduced to as low as by about 70%, and these LDLs are maintained for as long as the injections are made every 2 weeks. So this is a very exciting new area, and I know there are some discussions of this in your program. The ongoing TIMI trials that we're doing, one is ENGAGE, which is with a new 10A antagonist, edoxaban. Trial is completed. We're wrapping it up. Hope to present it pretty soon. Improve it with ezetimibe. The SOLID trial with an LP-PLA2 antagonist, daraplatinib, is nearing completion of enrollment. Has reached completion of enrollment, and it's the follow-up phase. The SAVA TIMI 53 trial done with Professor Itamar Raz. This is with a DPP4 inhibitor in patients with diabetes and coronary disease, high-risk patients. Pegasus TIMI 54, P2Y12 antagonist, ticagrelor in the post-MI period, and REVEAL, the 30,000 patient trial that I talked to you about with the CETP inhibitor that we're doing in anacetrapib. I have to say that in our experience with TIMI, and now dates back to almost 30 years of doing international collaboration, we have had tremendous cooperation from Israeli cardiologists, virtually every trial the Israel cardiologists have led, not only in the quantity of the work, but especially in the quality, and I want to express the appreciation of our total group. All right, so let me finish by giving you a couple of take-home messages. The first one is to remind ourselves of the immense importance of medical school experience with inspiring mentors. That is certainly what changed my life. And there is a tendency, particularly in specialties like cardiology, and there's a tendency, I think, around the world, it certainly exists at Harvard, that we focus more on training our fellows and residents. And, but I think the work with the students is probably the most important that we can do. Second take-home message, identify important problems. The questions you ask are of overriding importance. And it's how to frame the question that's absolutely critical. Don't just do it. The requirements for a satisfying career in research. Research has to be seen as an end in itself, not a means to an end. For many, many people all over the world, I see research people for whom research is a means to an end. It's a means to become recognized. It's a means to make more money. It's a means to have more power, to be promoted, all of those things. But that is not why people should do research. There has to be the thrill of the chase and the joy of this discovery, that is answering an important question. Because people who do research where it is a means to an end, they usually burn out. They usually burn out after a while. And there has to be internal motivation for research. It certainly isn't to make more money. There are many ways that you can make much more money than you can in research. And finally, research is not a one-man show or one-person show. It requires input from colleagues and from training now. And it frequently is multinational. Certainly it is for us multinational. We need the input from colleagues everywhere, and especially here in Israel. And therefore, this leads to the critical importance of team building. And the critical importance of team building means to recognize everybody who contributes and to make sure that they receive sufficient recognition. So thank you very much for honoring me